Okay, so today we're diving into a topic that's, well, it's pretty vital, really. We're talking about bleeding disorders and those meds that manage how our blood clots,
Mm.
anticoagulants and antiplatelets.
Yeah, this stuff can be pretty complex, but it's something that, most of us will probably encounter at some point, either personally or, with family or friends.
Absolutely. And whether you're, prepping for a medical procedure or just trying to wrap your head around a treatment plan, or maybe you're just one of those people who likes to be in the know, this deep dive is for you.
Right on.
We really want to break this down, make it clear, like what exactly do anticoagulants and antiplatelets do? What are bleeding disorders all about? And what are the big things you got to keep in mind when procedures, medical or dental, enter the picture?
Sounds like a plan.
So let's get right into it.
Okay, so first off, it's just amazing how intricate and balanced our body's clotting system is. I mean, we need to work perfectly, right? Gotta stop bleeding when we get hurt. But then we also gotta make sure clots don't just pop up where they shouldn't.
Yeah, that's a really good point.
And the medical document we're looking at today, it lays out a pretty solid foundation for understanding this whole delicate dance. What happens when things get out of whack.
It totally does. And one of the first things it jumps into is why someone might even need to be on those anticoagulants or antiplatelets in the first place.
Right, right.
It lists a whole bunch of conditions, things like angina,
Mhm.
heart attacks. Those fall under what are called ischemic heart diseases.
Right.
Then there's a history of cerebrovascular accidents, things like strokes and certain irregular heart rhythms. Those are called cardiac arrhythmias.
Uh-huh.
And then there's, folks undergoing dialysis for kidney problems, or if someone's had uh, thrombophlebitis or deep vein thrombosis, those are the clots that form in veins.
Yeah. Yeah, it's pretty clear these medications are, well, they're vital, really, for managing some pretty serious health situations where the risk of those dangerous blood clots, it's just higher.
Right. And when you connect that to the bigger picture, I mean, all these conditions, they have this underlying theme of, an increased risk of those unwanted blood clots forming, inside the body.
Absolutely. And those clots, they can block blood flow, and that's when things get really, really serious. We're talking heart attacks, strokes, the works. So these medications, they're really like a way to kind of lower that risk, like a safety net.
Yeah, totally. No, it's easy to lump all these blood thinners together, right? But the source, it really lays out the difference between antiplatelets and anticoagulants.
Yeah, it's important to make that distinction.
So antiplatelets, those target platelets. Platelets, think of them as like these tiny, sticky little fragments in your blood. They're like the first responders when you get a cut or something, when a blood vessel gets injured.
Right, they rush to the scene.
Exactly. The document mentions they actually release something called platelet factor 3, and this is like a key player in the whole clotting process. And this release, it could be triggered by substances like thromboxane and ADP.
So what's fascinating here is that antiplatelets, they actually make those platelets less sticky, less likely to clump together and form that initial plug. And that can eventually lead to a bigger clot.
Oh, I see.
And, a common example that a lot of people might be familiar with is aspirin, which is an antiplatelet.
Okay, so that's how that works. And then on the flip side, we've got the anticoagulants. They work a bit differently, right?
Mm-hmm.
They actually go after these things called coagulation factors. These are proteins in the blood that come into play a little later in the clotting process. It's like this whole chain reaction, a cascade, that ultimately leads to a solid clot made of this stuff called fibrin.
Precisely. So while those antiplatelets are working on that initial stickiness, those anticoagulants, they're interfering with the blood's ability to, like, fully solidify.
Oh, interesting. So it's like two different approaches to the same problem.
Exactly. And that's why, a doctor might prescribe one or the other, or sometimes even both. It all depends on the specific situation.
Right, because each person's health picture is different. Now, here's something that might sound counterintuitive. The source really emphasizes that generally it's not recommended to stop taking these medications before procedures, even non-surgical ones.
Yeah, that can seem kind of strange at first, right?
It does. If you're facing a procedure, you think, okay, I need to stop the blood thinners to avoid bleeding, right?
Yeah, you'd think so.
But the source, it stresses that, the risk of a dangerous clot forming, if you just suddenly stop, can actually be higher than the risk of some extra bleeding during the procedure, especially if the doctors can manage that bleeding with local techniques.
Right, like, applying pressure, special dressings, that kind of thing.
Exactly. It even mentions a medication called desmopressin. This can sometimes help to control bleeding.
And it's worth noting that this advice also applies specifically to aspirin, especially for folks who've had a heart attack or a stroke, or even those taking it preventatively. They say don't stop it, rely on local measures if bleeding comes up.
It really goes back to that delicate balance we were talking about earlier.
It does, it does.
Okay, let's zoom in on anticoagulants specifically.
Okay.
The source tells us they're recommended to prevent and treat something called venous thromboembolism. That includes conditions like deep vein thrombosis, where clots form in those deep veins. And they're also used to prevent strokes in folks with a kind of irregular heartbeat called atrial fibrillation.
Right, that makes sense.
And then it breaks down these oral anticoagulants into two main types: direct oral anticoagulants, or DOACs, and vitamin K antagonists, also known as VKAs.
So it's interesting how DOACs have kind of become the go-to, the first-line treatment for many patients with venous thromboembolism and a specific type of atrial fibrillation called non-valvular atrial fibrillation.
Right.
But the source points out that vitamin K antagonists, things like warfarin, they're still the preferred choice for folks with mechanical heart valves, and another type called valvular atrial fibrillation. Part of the reason for that is VKAs have been around longer, and their effectiveness in those specific situations is pretty well established.
It's like they've got that track record.
Exactly.
And they work in different ways too, right?
They do, they do.
So DOACs, they directly block the action of specific coagulation factors. They kind of target either factor 2 or factor XI. So it's like they have this more immediate effect on the whole blood clotting process.
Right, right. And then you've got the vitamin K antagonists. They work by messing with the body's ability to produce several vitamin K-dependent clotting factors. It's like they're hitting the production line, not the workers themselves.
Interesting analogy. So because they're affecting production and not the factors themselves, it takes longer for them to kick in, right?
You got it. And that's why the source mentions when you start someone on a VKA like warfarin, there needs to be this overlap of at least 5 days with an injectable anticoagulant just to make sure they're protected from clotting while the VKA starts to work. Those injectables are often called parenteral anticoagulants.
Right, that overlap period is crucial to maintain that continuous protection.
Absolutely. Now, another important point the source highlights is regularly checking a patient's bleeding risk while they're on these meds. Doctors often use tools like the HAS-BLA-D score. It takes into account all sorts of factors that can increase someone's bleeding risk. And it's really important, the source says, to address any modifiable risk factors, things that you can actually change or manage to lower the risk.
Right, so it's not just about the medication itself, it's about the whole picture.
Exactly. You got to look at their lifestyle, their other health conditions, all of it.
The document also goes into detail about what to do if someone on a vitamin K antagonist has a major bleeding event. It mentions using vitamin K itself, which can reverse the effects, and a concentrated blood product called 4-factor prothrombin complex concentrate. And for DOACs, it's pretty amazing that we now have specific reversal agents. Darovasertib for dabigatran, and dexamethasone alpha for rivaroxaban, and apixaban.
Yeah, having those available can really make a difference in those emergency situations. They can be life-saving.
Oh, sure. Now, when we're talking about planned procedures, the source has some pretty practical advice.
Okay, what's that?
So, for patients on vitamin K antagonists, they say the INR, which is that standardized measure of how long it takes for blood to clot, it should be checked within 24 hours of any surgery, big or small, ideally on the same day as the procedure.
Makes sense. Got to have the most up-to-date information.
And here's another thing. When you're on anticoagulants, it's super important to be mindful of other medications you're taking. The source advises steering clear of aspirin and those other nonsteroidal anti-inflammatory drugs, or NSAIDs, things like ibuprofen or naproxen. They can also increase the risk of bleeding.
Right, you don't want to double down on that risk.
Exactly. They suggest acetaminophen, maybe with codeine if you need stronger pain relief, as a safer option.
Okay.
And they also list some antibiotics that should be avoided, or at least used cautiously. Things like cephalosporins, erythromycin, clarithromycin, and metronidazole. Penicillins and clindamycin are generally considered safer.
Good to know.
And they mention avoiding barbiturates and steroids as well. But the big takeaway here is to always talk to your doctor about any other medications you're taking or might need to take.
Absolutely. It's all about personalized care. These are guidelines, but everyone's different.
100%. Now, the source also talks about heparin, another anticoagulant usually given by injection. They recommend waiting at least 6 hours after stopping a heparin infusion before doing a procedure. Or, if it needs to happen sooner, you can reverse the effects with a medication called protamine. And it's important to restart heparin after a good clot has formed, usually around 24 hours after the procedure. They also mention that heparin is often used during kidney dialysis to prevent clots from forming in the dialysis machine.
Oh, that makes sense.
And for patients who are on both heparin and undergoing dialysis, if they need surgery, the advice is to try and schedule it the day after dialysis. That way the heparin is cleared out. But if surgery has to happen within those 6 hours after dialysis, then reversing the heparin with protamine is recommended.
Okay, that's good to know. Now let's switch gears a bit and talk about bleeding disorders themselves. The source defines them as conditions that can arise from a whole bunch of different things. We're talking problems with the blood vessel walls, a low platelet count, platelets that aren't working properly, those coagulation factor deficiencies we talked about, certain medications that can affect clotting, or even problems with the body breaking down clots properly. It's a lot to consider.
It really is. And the source uses hemophilia as a prime example of a bleeding disorder. They explain that it's hereditary, meaning it's passed down through families, and it's caused by low levels of specific clotting factors.
Right.
The most common type, hemophilia A, it's due to a deficiency in factor VIII. Hemophilia B is due to a deficiency in factor IX. And the source really emphasizes the importance of talking to the patient's doctor, especially if their hemophilia isn't well controlled or before any invasive dental work.
Yeah, because the type and severity of hemophilia, they really dictate the risk of bleeding and the precautions you need to take.
Yeah.
And understanding that severity is so crucial. I mean, it directly impacts how likely and how severe bleeding might be. The source actually provides a classification system based on the percentage of normal clotting factor activity in the blood.
Oh, that's interesting.
So mild hemophilia is when someone has between 6% and 49% of the normal factor level. In these cases, bleeding usually happens after some major trauma like a serious injury or surgery. Moderate hemophilia is defined as having 1% to 5% of the normal factor, and bleeding can happen even after minor injuries. And then there's severe hemophilia, where the clotting factor level is less than 1% of normal.
Wow.
Sadly, this means spontaneous bleeding can occur without any obvious injury. It just underscores how critical it is to understand the severity of the condition.
I can imagine how that would impact someone's daily life. It must be really challenging. The source also mentions that there are certain patterns you might see in lab tests for someone with hemophilia. The PTT, which stands for partial thromboplastin time, is a measure of how well one of the clotting pathways is working, and it's usually prolonged in hemophilia. But the PT, or prothrombin time, which measures another clotting pathway, it's usually normal. And the platelet count and bleeding time are typically normal too. The source even gives the normal range for PTT, about 25 to 36 seconds.
These differences in the lab results, they can really help doctors distinguish hemophilia from other bleeding disorders. It's like putting the pieces of the puzzle together.
Exactly. Now, when it comes to dental procedures for patients with hemophilia, the source actually has some good news.
Okay, what's that?
They say that general dental work and simple restorative procedures, like fillings, are generally considered safe.
That's reassuring.
And after a tooth extraction, no matter the type or severity of hemophilia, the source recommends using what are called antifibrinolytic agents. One example they give is tranexamic acid. There's a specific dosage and duration in the document, but we won't get into those details here.
Yeah.
They also advise a soft diet for about a week after the extraction and a follow-up dental exam within 24 to 48 hours to check for any bleeding.
Yeah, it's all about minimizing those risks. And there's also some specific guidance on local anesthesia techniques that's super important for these patients.
Right.
The source recommends techniques like infiltration, where the anesthetic goes right into the gum tissue, and intraligamentary and intraosseous injections. But they say to avoid block injections, like the inferior alveolar nerve block, which numbs a bigger area, and also intramuscular injections, injections into the tongue side of the gums, and those into the floor of the mouth.
It's fascinating how this specific technique can make such a difference.
It is. It all comes down to the blood supply in those areas.
Well, that makes sense. Now, this is interesting. The source points out that if a dental procedure doesn't involve messing with the soft tissues, things like just checking the bite or taking impressions, those might not require any special precautions for folks with hemophilia.
That's good to know.
And just a reminder, aspirin and those other NSAIDs should be avoided in these individuals because of how they affect platelets.
Right. Always good to emphasize that.
For sure. And finally, when it comes to more involved surgical procedures for patients with hemophilia, how they manage it really depends on the severity.
Yeah, it makes sense that the approach would be different.
So for milder cases, they mention a medication called desmopressin, which can help release stored factor VIII, and antifibrinolytic medications like aminocaproic acid or tranexamic acid to prevent excessive bleeding.
Okay.
But for those with severe hemophilia, the source stresses that it's crucial to consult with their hematologist to figure out the specific factor replacement therapy they'll need. The document doesn't get into those specifics, though.
Right, that would be a whole other deep dive. So, wow, we really covered a lot of ground here. We've looked at how anticoagulants and antiplatelets work, explored the factors behind bleeding disorders using hemophilia as our main example, and talked about those crucial considerations for medical and dental procedures in all these different scenarios.
It's clear that managing these situations effectively requires a good understanding of how the body clots blood and the impact of medications and underlying conditions. It's pretty complex.
It is, but it's so important. And, this isn't just information for doctors and dentists. Having a basic understanding of these concepts can empower you, our listener, to be more informed about your own health or the health of your loved ones.
It allows you to have those more meaningful conversations with your healthcare providers. Ask the right questions.
Exactly.
Here's something to think about. Given how intricate blood clotting is and all the factors that can disrupt it, what do you think the future holds for personalized medicine and developing even more targeted treatments for people with these conditions? It's a field that's constantly evolving with so much potential.
It really is. Lots to be hopeful about.
Thanks for joining us for this deep dive. We'll catch you next time.